So good evening, everyone who is joining us for our 7 Starling webinar series designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with perinatal mood and anxiety disorders. My name is Nazaneen Homaifar, and I'm a practicing OB-GYN in Northern Virginia and the medical director at 7 Starling. 7 Starling is a digital mental health solution that provides virtual, individual, and group therapy for the full spectrum of women's health needs, including miscarriage and infertility, and prenatal and postpartum mood and anxiety disorders. I am thrilled to be joined by Dr. Crystal Clark, an associate professor of psychiatry and behavioral health sciences and obstetrics and gynecology at Northwestern Feinberg School of Medicine. She specializes in mood and anxiety disorders and is an expert in the treatment of women's mental health across the reproductive lifespan. She has dedicated her career to reproductive psychiatry and the advancement of maternal mental health. She's a researcher, educator, clinician, and thought leader, and also an advisor to 7 Starling. I'm excited to kick off. I need some water. I'm excited to kick off our provider series and chatting with her today about perinatal mood and anxiety disorders 101. Welcome, Dr. Clark.
Thank you for having me. I'm excited to have this webinar and teach people some things or give them a review of PMADS and the important things they should be looking out for. So thanks for having me.
Absolutely. I think we're going to learn a lot. Let's jump in. We have a lot to cover. We're being very ambitious about what we're hoping to cover. So today we're trying to cover baby blues, perinatal depression and anxiety, obsessive compulsive disorder, and bipolar disorder. So let's start with baby blues. And I'm going to try and give us a few minutes at the end for questions, but we'll try and take about 5 minutes per condition. Dr. Clark, with baby blues, can you remind us what the clinical definition is and what the most common presentation is?
Absolutely. So baby blues is really a normal physiologic reaction to the significant hormonal changes that are happening post-birth. I mean, I always say to my patients, it's like, you're falling off a cliff in terms of the changes in the hormone concentrations. And it typically presents within the first few days postpartum, may peak the 5th day and should dissipate by the 10th day postpartum. This is not a long-lasting thing, but it presents with irritability, emotional lability. A lot of patients will be very tearful and they're like, why am I crying? Also anxiety, fear. Those symptoms can be very strong, but it typically, again, goes away within 10 days. And many women are impacted by this. Approximately 80% of women who have a baby will experience the baby blues.
So, and I guess when I was training too, I thought of it as something that could last up to 4 weeks. Do you see it ever lasting longer than the 10 days? And would you be concerned if it lasted longer?
I'd be very concerned if it lasted longer. I would start to worry about postpartum depression at that point, which is why I typically see my patients at the 2-week mark, 14 days postpartum, especially in someone I think has high risk factors for having postpartum depression. I intentionally wait to see them at the time in which I think the postpartum blues should be over. A month would make, I'd be getting ready to start or encourage treatment and taking further action.
And then for that person who has a history of depression and anxiety, maybe not in the pregnancy, but they're asking you, how am I going to tell the difference between baby blues and something else? What would you tell them? And how do you screen for baby blues?
Yeah, so I would say I don't even really screen for baby blues because I expect that so many women are having, are experiencing it. I'm more so, counseling women about, okay, don't be alarmed if you're experiencing some increased emotional lability, you're crying out of the blue, you're feeling a little on edge. Let's not, get worried about that right away. If that persists, that's when we start to get concerned about, well, is this really baby blues or something else? And we start, getting past the 2 week mark. We're starting to think about, is this depression? Is this anxiety? Or might this be something, is it bipolar disorder? Which PMAD might it be? And how I'm screening for that is asking those questions, telling the patient, if it persists more than 2 weeks, which is the definition of depression, for instance, sadness, lack of interest, irritability that's persisting more than 2 weeks, then we're worried about this being an actual major depressive episode or postpartum depression. If it's anxiety that is persistent, where it is consuming that patient more often than not, early in the postpartum period, lasting again beyond 2 weeks, I'm concerned that this is more of a postpartum anxiety. And then of course, bipolar is a little bit different, which we may talk about a little bit later.
Okay, thank you. That's really helpful. And I will share with the audience. For me, it was Miley Cyrus's song Malibu. Whenever I would hear it postpartum, I just started crying. And I was in a Starbucks once on my 2 week
Yeah.
postpartum check, and it came on, and I lost it in the Starbucks. So
Yeah.
it was a humbling to experience it and get a sense of like, oh, this is
Yeah.
true, really out of my control.
Yeah.
Um,
And I just want to jump in and say that, and it varies from woman to woman. So, it's not impossible to have those symptoms lingering. But I do think any care provider or any patient, if it's past 2 weeks, start monitoring more closely because, yeah, it's like that could be something else brewing.
Speaking of, I'd like to move to perinatal depression. And this is, I'm referring to depression either in pregnancy or postpartum. And I know you mentioned some of the symptoms of irritability and sadness, but what other common presentation do you find in this period? And um, anything that distinguishes it um, from previous depression versus depression that's related to the perinatal period?
Yeah, great question. This is one that varies in patients. Patients who have had depression prior, whether that's in pregnancy or prior to pregnancy, might describe some different symptoms, or they might just say it's exactly how they felt before. Say they were well, and it has come back. They recognize it right away. Sometimes the symptoms are more intense, but what they're complaining about are your general symptoms of depression. Nothing really different in pregnancy versus postpartum other than the sleep deprivation maybe. But they're complaining of, it could be lack of appetite or eating too much. It's, the fatigue, which can be sometimes very difficult to distinguish between the pregnant patient versus the postpartum patient because they're sleep deprived anyway. But it's an overwhelming heaviness, just cannot get any rest uh, and recover, so to speak, or reset. Which in pregnancy, unless it's, if it's the first trimester, you're like, oh, well, it's first trimester. But by second trimester, if they're still really fatigued, you're like, yeah, something's probably not right. Other things being the irritability, the lack of energy, again, and they vary like I cannot, even if I get sleep, I can't regain any energy. It's more pervasive and overwhelming than just the energy of the lack of energy due to not getting your regular amount of sleep. Feeling hopeless or worthless, feeling guilty, like they're doing something wrong. Again, that irritability, sadness, and lack of interest. Of course, interests change when you have a child. So again, it's all about what you're distinguishing. In pregnancy, it's a little easier to say, okay, lack of interest, you don't feel like going out with your friends, and you're not like the end of your third trimester, so you're
Okay.
not uncomfortable. It's just that you don't want to be bothered, you're isolating, versus postpartum where someone's like, well, I'm trying to take care of the baby. Of course, I'm not trying to go out, but even little things that they used to like to do, they won't have any interest in. Even if someone is taking care of the baby for them, they won't have any interest. So similar symptoms, just it's just a different context.
I heard some things that as an OB-GYN are really helpful for me. The fact that you said in the second trimester, if that feeling of fatigue is still really overwhelming,
Yeah.
that that for me should be a red flag. And also feelings of guilt. I don't
Yeah.
necessarily know that I associated that with depression before. And
Mhm.
goodness knows I mean, I hear it a lot. So trying to tease that out. And that brings me to my next question is
Mhm.
we know there are screens out there and we can open up a can of worms. Hopefully we'll have a webinar at some point about what is the best way to screen for perinatal and postpartum
Mhm.
depression. But how what do you usually recommend to screen for it?
Yeah, so as we've discussed before, there's no perfect screen, and hopefully we'll get better screens in the future. But right now, the gold standards for screening for depression are the Edinburgh postnatal depression scale, as well as the Peer Health Questionnaire, also known as the EPDS and the PHQ-9. And both of those are great places to start and have been well validated in this population of patients. The drawbacks are they have not captured maybe the cultural differences well, or the cultural language that might vary from community to community in terms of describing some of these symptoms. But it does capture, I would say, a good amount of the population who is experiencing depressive symptoms postpartum.
So what would you do if you had a positive screen?
Yeah.
How do you initially manage it and when do you decide on medications?
Yeah, great question. I tell people just because you get a positive screen doesn't mean you have to take medication. A lot of patients are scared of that and may even rate themselves lower trying to avoid being diagnosed for one because of the stigma, but also fear of taking medications, especially if they're choosing to breastfeed. So therapy is a good place to start. Everyone does not need medication. Typically, if someone has a moderate score or a mild to moderate score, they can get by with psychotherapy alone. As I get further into moderate to severe scoring, treatment is in terms of medication is really recommended. And I tell patients, it's really also about the difference in the length of time of suffering. Say someone is mild to moderate and could do psychotherapy, they could also really benefit from medication a lot quicker, but it is a personal preference. If they're severe, our concerns are that it might be that much harder to recover from, and that they might be at risk of other things like suicide, which is a leading cause of death for moms. So we really don't want to get that far.
That's and so how much time as a referring provider would you give uh, to determine if you do feel comfortable with
Yeah.
medication management or if you do have to consider a referral to psychiatry? How much time would you want to give the patient to see how
Think
they're
about
doing?
it. Yeah, I not too long. Depends on how severe, mild to moderate. I'm like, okay, think about it. Come back in a couple of weeks. I don't want 'em to, uh, no, 2 or 3 weeks is fine. But if they are moderate to severe on the scale, then I'm like, let's check in next week. Because this could, get worse, and we really want to intervene. I want you to think about, come back, ask questions, talk to your partner, family, whomever, come back, ask questions. And I might see that person weekly until they make a decision.
How would you, and do you have any resources, any links or like associations or organizations that you like to share and recommend for your colleagues outside of psychiatry?
Absolutely. I definitely highly recommend Postpartum Support International, which is really great for looking up some of this information about the different disorders or the PMADs. Also, great for looking for referrals to a psychologist or therapist or psychiatrist in your particular area or country, since it is an international organization, as well as just looking up groups and things like that. I will also recommend womensmentalhealth.org, which is more so for, learning more information about these different disorders. And finally, Marcy of North America, I just have to plug them as the
As
uh,
their former
media
president.
past president. Yes. So, but yeah, in terms of finding out more information and it, and also thinking about, the non-gestational carrier, who also might be impacted by this period of time and vulnerable to depression and anxiety during this period of time.
Absolutely. I'd like to move on to anxiety. How would you distinguish depression from anxiety in this population?
Great question. Sometimes they look very similar. So I would say that when you really dig though, the woman with anxiety during this period of time is not so much lacking interest or feeling sad. They're like, no, I don't feel sad. No, I'm yeah, I might not be doing the same things I used to do, but it's not because I don't want to do them. And they're more so very just worried about everything, like, so much that it's so excessive that it's affecting their function, their ability to, get things done and focus on things because they're so concerned about, well, what if I'm feeding the baby wrong? What if I didn't dress the baby right? Just every little thing during the day is anxiety provoking and something that they're excessively worrying about. They may also be very irritable. Thoughts are all over the place, not in a racing fashion like what we see with bipolar disorder, but more in a they just have a lot of things on their mind. They're not sleeping well, likely because their thoughts are just all over the place when they're trying to go to bed. They can't fall back to sleep when they're when the baby is sleeping, things like that. And we sometimes see a similar sleep disturbance with depression, but in depression, it's not usually a result of the thoughts being all over the place. It's just they can't sleep for, because of the mood disorder.
And so, how would you screen for
Mhm.
anxiety?
Yeah. So the generalized anxiety disorder scale, which we refer to as the GAD or GAD-7, is a great screen, and it's really, really easy, quick 5-minute scale. And you're just basically asking the patient, how have you felt in this past 2 weeks? And it's asking about excessive worry, guilt comes back up, irritability, inability to relax, restlessness, inability to sit still, things like that. And yeah, if a patient's scoring, the scale is from 0 to 3 for each question. If they're scoring 2 to 3 on every question, then you can pretty much conclude that they're feeling very anxious, and that can be treated again with therapy or medication.
And when you think about, it sounds like my next question was going to be about management. So it sounds like therapy would be the mainstay. Are you using the same types of medications to treat anxiety that you are for depression? So is it still SSRIs?
Absolutely. The SSRIs as well as SNRIs, both are antidepressants and anxiolytics. And you want to use those versus using a benzodiazepine such as Xanax or Valium, or lorazepam, or also known as Ativan, which are easy to go to, quick fixes, but you don't want this woman to get addicted to them. And, it's one thing if you need to use it for a week to really kind of help a woman reset as this other medication is kicking in, but to give that as the treatment ongoing definitely sets them up for an addiction. And that's not what we're trying to do. We really want to treat the illness.
Just, and this is something I was just thinking of, like, are you going to be prescribing, without getting into too many details, are you going to be prescribing for anxiety the same way that you would for depression? So if you have an SSRI that is your go-to for
Mhm.
safe for breastfeeding, is it the same dosage?
Not necessarily. Depends on it's very, I'm all about personalized care. So it's very individual. And so just to use an example, hypothetically, say we're using Zoloft because that's commonly used, very popular. Zoloft is usually dosed from 50 to 100, to 200 milligrams. So going up by 50 milligram increments. That's to treat depression or anxiety. But for anxiety, we might go a little bit higher. We might do 250, 300, if that woman has not responded fully by the time we get to 200, and those residual symptoms are still pretty impactful. You don't see as high of dosing often with depression unless it's just a severe case, but most times, 200 as the max dose would be sufficient. Similar with other SSRIs or SNRIs, you may have to go a little bit higher. We see it more with SSRIs than we do with SNRIs, and SNRIs are like Wellbutrin, for example. Mhm.
That's helpful. That gives me so much more context when I have patients who come in with perinatal depression versus anxiety. And sometimes I'm like, wow, that seems like a lot, but I'm going to pay more attention now and see if it's anxiety is their main
Yeah.
condition or depression, and keep
Yeah,
that in
absolutely. Yeah,
mind.
and I try to tell people the doses is, first of all, it depends on the disorder, but also because it depends on the individual. 200 doesn't mean it's a lot. It means that that's what that woman's body or receptors takes. It doesn't mean that, oh, you're more severe, because not necessarily so. Just means that that's the dose that works for them.
Thank you for reframing that and teaching me that too. I want to be able to. I like how you phrase that. Let's move on to postpartum obsessive compulsive disorder.
Yeah.
What is the incidence of OCD in this population?
Yeah, amazingly, the incidence for all of these are, somewhere around 15 to 20%, for with the exception of postpartum depression, which depending on which is about the same too. It's 14 to 22% or whatever. But yeah, OCD is about the same as well, which is I think fairly high.
Right.
Um, yeah, so it's pretty frequent in postpartum women.
And how does it present? And how do you,
Mhm.
well, go ahead. How does it present?
Yeah, so it presents, again, it's very contextual. So we know that obsessions are these ego dystonic, meaning that they're the patient doesn't really own them. It's like, I don't like this thought. This is not consistent with my ego, but I keep having this repetitive ego dystonic it's bothering them, thought that it just keeps popping into their head. And they might be compelled to also have to respond to that thought with a behavior to help reduce the anxiety associated with the thought. So postpartum, you see some bizarre things though that patients are embarrassed to talk about and might scare providers. So, for instance, you know, a woman might feel like they have this obsessive thought to throw the baby. They're scared by the thought too. They will tell you, "I don't want to throw my baby. I absolutely, it's not what I want to do, but I just have this thought keeps entering my head that I'm gonna throw the baby downstairs." So then their compulsion is to then avoid walking down the stairs with the baby. So then they just won't walk down the stairs.
I see.
Yeah. Um, it could be they're worried about, touching. I mean, again, it could be bizarre. They're worried about touching the baby's genitalia or something,
Mhm.
like molesting the baby. Again, they'll say, I would never want to do. I mean, they're just like mortified that that thought has even popped into their head, but it keeps coming in their head and they're bothered by it. And so then their compulsion might be, I'm just not going to change the diaper because I'm scared I'm going to touch the baby inappropriately. So,
So is it then with OCD that people act on their intrusive thoughts? Like, because you know what, or what's the difference between intrusive thoughts and OCD? To
yeah,
me,
no, they have, no, that's the obsessions are the intrusive thoughts that are repetitive and ego dystonic. They don't act on them, they act to avoid them. That's what
okay,
a patient with OCD does. They're acting to avoid whatever they're worried about. So, particularly in the postpartum period. So again, using that woman who is having an intrusive thought to throw the baby downstairs, her action is to avoid the stairs so that I don't throw the baby down the stairs. So they're not acting there. She's not gonna act on it. We're not worried that she's gonna actually try to throw the baby down the stairs.
sure. Sorry, and I meant to say
Yeah,
that's what I meant. That like she was
yeah,
when you hear from a patient what they're doing to avoid that
yeah,
thought, that
yeah,
should cue you that there could be OCD.
absolutely,
Okay.
absolutely.
So how do you screen for it? Because I know for sure I'm not screening in my practice.
Yeah, no, this is a great one. So there's not a, at least I'm not aware of any just standard great postpartum OCD screen, but I would recommend that the OB-GYN or mental health provider or primary care physician who sees this postpartum mother ask ask the patient, are they having unusual thoughts? I mean, usually that in itself is a kind of opens the door. And to remind them, set the stage by saying it's not uncommon that you might be experiencing some unusual, bizarre thoughts that you feel like might even embarrass you, and you feel like you would never act on whatever these thoughts are. But we check for them so that we can, help you if needed. And some people will be looking at you like you have two horns, like coming out of your head, like, huh, what? Um, I might give an example like having thoughts to throw the baby or something, even though you would never do that. And after I've given an example and they're still looking at me like I have two horns coming out of my head, then I'm pretty, in most cases, pretty confident that they're just not experiencing that. We can move on.
Okay.
Others might be like, well, actually, and it might take a moment. So give them a second to just, get comfortable with saying what they're thinking, because it can be very shameful. Um, and they may not have shared it with anyone else, so they might go on to tell you about some bizarre thoughts they're having, and I would just normalize that for them. Yeah.
And in terms of helping them with that, I love that we should absolutely normalize it. Would we then refer to the same, is it psychotherapy and
Yeah.
medication management for?
Yeah, absolutely. Same treatments here. You know, it's again, this is very uncomfortable for the women that are experiencing this. I think again, medication is going to help them not suffer as long, but some will not want medication. So, and therapy is actually very effective. Cognitive behavioral therapy, in particular, for this condition.
Okay. Thank you. And we have 3 minutes left, and your expertise is in bipolar disorder. So I want to make sure, your expertise is in many things, but this in particular, what is the common presentation of bipolar disorder in pregnancy and postpartum period?
Yeah, so great question. I love to tell people that, and that bipolar disorder actually presents as a depressive episode, and most commonly in pregnancy and postpartum, meaning that they look just like any other woman who does not have bipolar disorder and is depressed in pregnancy or postpartum. And they can also present very anxious. So that's, of course, very confusing. Um, for the person who's like, oh, okay, well, it looks like they're scoring high on the EPDS. They absolutely might score high on the EPDS or the PHQ-9 because they're in a depressive episode, and that's the most common episode to onset or recur for bipolar disorder in pregnancy and postpartum. So really it's about asking and using maybe a mood disorder questionnaire, not the we need better assessments and screens for this disorder, but that's the best we have right now. It's really about asking about a history or a time where the woman has been able to go for days without sleep, felt really good, or felt really rageful. Do they have family history of bipolar disorder, mom, dad, a sister, brother? Um, have they had times where they're just very impulsive and that kind of come in waves or something like that? And so that it's that history that is most telling, because they're likely going to be in a depressive episode. In the rare case where you have someone that presents manic, you'll know because they're like, oh my gosh, this is the best thing ever. I just had a baby, and their, life is, better than it's ever been. And so, and although there are plenty happy mothers out there, there you're like, you're just a little too happy. Not, oh, I didn't sleep. It was okay. I'm great. They're just on top of the world, truly, and not in any bizarre way necessarily. But just like they have more energy than usual. They're very happy.
What would you do then if you found that to be the case? Because they seem to be coping really well, but we know it's a manic disorder. So how would you talk to
Yeah, so,
them?
So you have to remember that what goes up must come down, and they're not going to stay that way. And so they're going to go crashing, and that's not going to be good. So it's very important to get them in to see a psychiatrist as soon as possible, um, to start talking about medications, because that crash can be quite devastating, and quite impairing in terms of them taking care of the baby.
How and is the incidence the same as what you were mentioning for OCD,
Um,
or what's the yeah?
yeah, so it depends on it depends on if they have a history of mood disorder already. They're like almost 50% more likely to have a recurrent episode during the postpartum period. And in terms of new onset, the statistics aren't the best on that, mainly because it's often missed, because people think it's a depressive episode. So I'll tell you the best study we have, though, that looked at 10,000 women in the Pittsburgh area. 22.6% of those women actually have bipolar disorder who scored a positive screen on the EPDS. So, if that's any indication, we're expecting, again, that 20% are experience bipolar disorder or have bipolar disorder, bipolar depression, postpartum, just like the 14 to 20% that are experiencing depression.
Do you have, I know it's 6:01, but just the resources you mentioned before with depression, do those have information on bipolar disorder as well?
Yeah, all of those have information on bipolar disorder. And I'll throw out one more reference, and that is mother to baby. For those who do consider taking medications during pregnancy or lactation, for postpartum depression, anxiety, OCD, or bipolar disorder, mother to baby gives you information about those medications and the safety and risks pertaining to those medications. And we'll offer a free consultation for those who want a second opinion.
Oh, great. Mother, oh, they will. I didn't know that. I use mother to baby all the time. I tell my patients to go to the fact sheets.
Yeah, absolutely.
No. Well,
Yeah.
Dr. Clark, thank you so much for this crash course in perinatal mood and anxiety disorders. I think we covered a lot of ground.
Yeah, we did.
And I don't see any questions from the group, but to our listeners, we're so happy you made time to join us tonight. At Seven Starling, we are committed to providing excellent perinatal mental health care and would love to support you and your patients. Please check out our website, sevenstarling.com, to learn more about how we may help you in your own practice. If you like this webinar, please subscribe to our newsletter so we can keep you informed about future events. I hope that I'll get to speak to Dr. Clark again, and I hope everyone has a great night. Dr. Clark, thank you for sharing your knowledge with us.
Thank you for having me.
Absolutely. Take care.